Okay, it is March 7th, 2023, and I'm Dr. Duke Machen. We're broadcasting surgery live from the Duke Spine Institute. Our patient is coming to us from the Orlando area where he lives, and he has been suffering with back problems now for years, and the pain is going down to the right leg. He has an MRI that shows multiple herniations in his back. Shot. Let's get an AP. I may be too lateral. I want to see.
Try to keep your head still. You're doing very well. We're locating your disc problems right now.
And yeah, that's good. And when you get to a certain age, these discs become degenerated discs. So that the damage to the actual disc starts as a herniation and eventually becomes a degenerated disc. Huh? So, all right. Now, the hardest part of the surgery is the L3-S1, and I'm trying to find the best entry point. Lay still. Shot. And the entry point that's going to be the best is one that allows me to get to the 5-1 disc safely. Okay. You're fine. Lay still, Sean. A lot of arthritis, I can feel it. Hitting a bone spur there, Sean. You're okay. Where do you feel that? Yeah, lay still. AP. So that's pretty darn good. As long as it looks good on the AP view, we can proceed. The L3-S1 is always going to be the hardest disc. That looks perfect. And that is the L3-S1. Jordan, what are you going to do when you've got 4 of the best fluoroscopes available in the world?
Cry happiness.
Tears of joy and happiness. All right. I could feel the herniation right there. Yeah, right? Shot. Shot. That's beautiful. You're doing great. You just lay still for me and we'll be done as soon as possible, and then you can be off to Brazil with your lovely wife and visiting your mother-in-law. How long are you going to be in Brazil for? All right. Interesting. He's going to be tough for me to get 4-5 and 3-4, all of them. I'm going to have to do a separate incision just because of his alignment. I could probably get this one. I'll try. So you're going to be there for about almost 10 days, basically? Uh-huh. You know, I've never been to Brazil. I would like to go someday, Shot. Anybody here been to Brazil? Besides our patient? Where do you feel that? Yeah, I apologize, but this is how we get to where we need to go. You're doing great. We're not having any problems. I apologize for the discomfort, but everything is going perfect. Shot? It's one of the bone spurs there. Shot. Right up against the end plate. I got something on my collar right here is bothering me. Just up the base of my neck. Maybe something plastic in there. The detector.
I think it's your necklace.
I don't think so. All right, well. It may be on my collarbone. Shot. All right, so you can see we're right at the back of 4-5. We talk about the Duke spine drilling that we sometimes have to do. There it is. Perfect. I am going to try for the last disc on the right side through the same incision. What concerned me is the angulation, but let's see how we do. We're first going to change that's really nice, Jordan. Perfect. You can see the 3-4 disc, if all 3 discs is the best looking. You okay? Yeah. You're doing great. Yeah, we may be able to get it. You ever been to Brazil? Yeah. I almost went. You have? Yeah. When did you go to Brazil? January last year? You said you go like every other year, right? All right. Let's go AP and see where we are. So it's looking good. Stay still. You're doing great. We're almost done. We're going to put you to sleep soon. Have you watched any of the surgeries being done? Yeah. What do you think about them? A little what? A little janky or shaky? Shaky. Oh. All right. So take a look at that 3-4. That is the nicest of the discs. It's the most preserved. So, all right. We're done with your right side, which is your worst side. We're going to start on the left side. Lay still. You're doing great, okay? We finished placing all the needles on the right side. Now I've just got to get your left side done. Num. I want to go a little higher, I think. If you lay still for another 10 minutes, we'll be done, and we're going to put you to sleep, okay? Okay. Give me some num. Uh-huh. Good. That's just some numbing medicine, that's all.
It'll get better.
Unfortunately, the numbing medicine is a bit uncomfortable sometimes. Yeah, I know the feeling. Shot. Do what to who? Is that your nose thing?
Yeah, the mask is. I got it.
Shot. Don't move.
We'll shut it a bit tighter, okay? How's that?
Shot. You're doing great. Almost done. Shot. I could slipping right through there. Let's go AP. So for those watching, this patient has 2 problems. He's got back pain and he's got leg pain, numbness, weakness, tingling, the usual radiculopathy we call it. He's actually got the radiculopathy on both sides, but he only has symptoms on the right. Shot. Is that it? Where is it? Is that it right there? Yeah, that's what I think. I agree. Where do you feel that?
Down my left leg.
How far down?
Half maybe third of the way
Does it
Third away to calf.
almost to the calf?
Third away into the calf.
Into the calf.
Yes.
All right.
Whoa.
Where do you feel that?
Left leg.
Left leg.
How far in your left leg? It's right on the
Not
facet.
far.
Shot? How far down?
Is it down to your knee?
Yeah. That's below the knee.
Below the knee.
Shot? Shot? Where do you feel that?
Yeah.
Let's go AP. All right. So basically, that's why our patients are awake for the beginning of the surgery. We want their help to make sure we navigate properly and to get their feedback. So that's looking pretty good. You can see the right side, we already have the 3 needles in position. And we're just working on the left side. The tip of the needle is very close to the back of the disc. Are you comfortable?
Okay. Yeah.
All right, you're doing great. I just need your help for, huh?
The fellow on the voice box couldn't pull that over.
Just keep it simple. I can't have a long conversation. Shot?
Pull out that thing a little bit. Whoa, whoa, whoa.
Where do you have it?
All the way down to the toe.
All the way down to his toes.
All right, shot. Is it better? The problem is we're so far below the nerve. I mean, the needle is low, really low. Is that better? No pain now? Huh? I'm going to try to go further south. Shot? I'm limited by the arthritis he has in his facet joints, which I can feel. Shot? Give me an AP. No pain in your leg now? Yeah, I'm right on the back of the disc. I feel all the bone spurs. I see, there's the pedicle. The pedicle on the left side is a little lower than the pedicle on the right. You see that? All right, let's go back to a lateral. I'm hitting against something bony, hard.
Whoa, whoa.
Where is it?
Yeah, left leg.
Left leg. How far down?
Whoa. Right on the knee.
On the knee.
So the problem, yeah, but that may be referred pain. I'm well below the nerve root. This is just referred pain, I think. Problem is getting into.
Whoa.
You're doing really good.
Oh, whoa, 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 yeah.
All right, let's go ahead and go for the. Let's do some num here. Lay still. You're all right.
Okay.
All right, we're gonna make our incision. Watch the needle or the knife. Watch the scope. It's pointing up. I'm gonna leave the last one that I was doing 5-1. How are we doing, guys? Jordan, fluoro? Oh, okay. All right. So right now, I'm gonna try to place the needle at left 4-5. See if we can't have some more luck with that one. Shot. What is it?
Oh, sure.
Can you,
I got you. Pick it. Let me see something.
interesting. Where are you feeling pain? Pressure? Ah, his blood pressure is high. So let's just stop for a minute and get his blood pressure under control. All right, let's get him comfortable. You're doing great. We're just going to take a minute and get you more comfortable.
Number 2 on the wall. Number 2 for them, please. Number 2. Please, you're going to have some light on now. There you go.
So I'm just going to hold off right now because the blood pressure is
You feeling better like that?
higher than I want it. He's just having some discomfort. We're trying to get a more comfortable position. And we will. I need him down around below 130. All right, do we have the discogram stuff?
Yeah.
I mean, we might as well connect those over here while we're waiting. So we're going to be doing a discogram in a moment.
That's okay? Cool.
Is that better?
Yeah.
Let's get him, is feeling better? Good. Let's get his blood pressure down. Let me know when you're ready to proceed. So far, we've just hooked up the discogram tubes to the right side. We're still waiting to finish accessing the left side.
We'll give you 10 strokes on your dossier. No problem.
10 strokes on what? All right. You feeling all right? All right, while we're waiting, Henry, why don't you show the audience a video on how do discs actually cause back pain?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Okay, welcome back. So we've working on making our patient more comfortable and getting his blood pressure in a favorable area. Obviously, laying on a table in the operating room and having needles stuck in you is not that comfortable. So we're going to buy some time while we're giving the blood pressure medicine time to work on his system. And we'll take a question in a moment, but I wanted to show you his pain is classic for lower back pain coming from a disc. Specifically, in his case, he's got 3 discs that are damaged: L3-S1, L4-5, and L3-4. He's actually had surgery done on his back elsewhere before he came here. I think he had a microdiscectomy or hemilaminectomy. Yeah. Where was your laminectomy done? Biospine. Oh. Don't tell me a name, that's fine. But it was done at Biospine. It didn't work too well, did it? Made it worse, he said. So this is, when was that done? Just a few months ago?
November of 22.
All right. So had surgery already done, didn't work. Now he's here at Duke Spine to get fixed, which we are going to fix you. I'm confident. I just want to get your blood pressure in a more favorable area, and it looks like it is coming down, which is good. I'm just going to wait a minute. You doing okay?
Absolutely.
All right, good. All right, so let's take the question.
This comes from Lubisa on Facebook,
Uh-huh. Hi, Lubisa.
and they asked, "Hello, what do you think about the application of stem cells in degenerative discs? Success rate percentage and pain relief? Thank you."
Yeah, stem cells, in my opinion, don't work for degenerated disc. We've tried them. And we've done PRP and stem cells. They don't work. I'm not aware of any studies that show stem cells work. And our personal experience here at Duke Spine is not work. So we don't do treatments that don't work. He's funny. Just move it a little bit. Let's get his right arm more comfortable. Looks like blood pressure is definitely coming down. I want to get it down a little more before we proceed.
How's that for you? Better? Okay.
Thank you.
You're welcome.
So the reason we broadcast is so everyone can kind of see what really happens during surgery. And, you know, as we have issues that we deal with, you can see how we deal with them. And blood pressure is one of those things that you don't want to be too low and you don't want to be too high. You want to be kind of in a nice range where it's safe to proceed with surgery. If it gets too low, then the brain and the heart don't get enough blood. And then if it gets too high, then the heart works too hard, but also you bleed more. So you want to keep it within a nice range where it's safe. Right now we're retesting and we're just going to wait until it's safe to proceed. Any more questions from the audience?
No current questions.
Let's run the video on how does the Duke laser disc repair actually work? What is being done?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. I was just having a conversation with our patient about YouTube and royalties for the videos. Sean? Yeah, that was... Where do you feel that? Where do you feel that? Yeah, it's normal. You're going to have that. We're scooting around your arthritic spine right now. I'm trying to get into that bottom herniation that's so bad. Shot. I can't see. Shot. That's good. Let's get an AP. Little pressure, just gentle pressure there. So we're going to use another view called an AP. Don't move the needle, whatever you do. Shot. Nice. That looks good, but it looks like it did last time, so let's see. He's got a bad pinched nerve on this left side at 5-1. That's why I really want to get down there and get it done. You okay? Yeah. All right. You're doing great. Hang in there. Where do you have that? Where? Perfect, perfect. Butt cheek, good. Butt cheek, I'm happy with.
Where's that going? Where's that going? Where's that going?
Left side again.
It's going into your leg? Down to your foot or no?
It's going down my foot.
Into your foot.
Your foot?
Yeah, it's going
AP.
all the way down my stomach.
All the way to his toes.
Yeah, but see, he's got so much narrowing there to begin with. Let's take a look. It's all right. When he tightens up, he narrows the foramen even more. Is it still bothering you?
Yeah, it's okay. No. Whoa.
Where is that sharp pain?
Maybe just below the last one.
Where?
Just below the last one. So is it
It's in your back.
in your back?
It's in my back, but okay.
Yeah, the thing is he's tightening up his muscles, tightening his foramen, pinching the nerve more. So, yeah, I know, you're doing your best. Let's go 4-5. All right, blood pressure is better. Let's see if we can get it even lower. Shot. All right, we're going to go for 4-5 right now. Shot. Now, we had a question earlier about stenosis, narrowing, and somebody said, hey, why treat stenosis if there's no symptoms? And my response was quite simply put, if the patient has abnormalities on exam, shot, then you have to treat it. If they have weakness, for example, shot, in their legs, numbness in their legs, maybe they're not complaining about it. Shot. Let's go AP. But they have it, right? And if you have pinched nerves and nerve damage, then you need to treat it even if the patient doesn't have symptoms. Oh, it's beautiful. All right, we're making progress. Blood pressure getting better. Still sitting there. Can you bring it down a little more? You're doing great. Lay still. We're almost done. And once I'm done, I'm going to put you to sleep, okay? I got one more to go. We did 5 out of 6 so far. You're doing great. I just want to get this last one. And I appreciate your patience with us. Yeah, I know. It's your left side. That's where we're working. Shot. I'm trying to get to your last disc. The number 3-4. On the left. Shot. Yeah. You're doing great. Bear with me. Shot. Need to be a little more north. Shot. That's perfect. Sneaking around the facet joint. Shot. All right, very good. We're almost there. Yep. Try to get comfortable, okay? Because we're just about to put you to sleep. Shot.
How's that?
Done. All right. Are you comfy? All right, we're ready to put you to sleep now. I just got to check one more thing, okay? How long have you had back pain? 1990. Who's going to do the math? 33. 37? 47. Oh my God. 90, 2000. All right, well, all right. Can we say 33 years? Are you okay with that? All right, so you've had back pain for 44 years. So maybe since the 80s. Okay, so 44 years of back pain. All right, 44 years of lower back pain. Sad, because we could have fixed this when I was doing this 16 years ago. 44 years. And remember, he's already had back surgery in Orlando. And it didn't help you at all, did it? Okay. Are you comfy? All right, good. How bad is that on a scale of 1 to 10? What's the highest it went?
6.
Is that where you typically get your back pain? Is that the area you get your back pain? All right. We call that concordant. So he had 6 out of 10 at L3-S1. Is it better now? Excellent. All right. No more pain now? How bad is that? What's the highest it went? 8? 8 out of 10. And is that where you typically get your back pain? He said yes. So it's concordant, meaning that's his typical back pain. So far, 2 out of the 3 discs we've tested are the cause of your pain. Now, normally you get mostly leg pain, right? On the right side. All right. How bad is that on a scale of 1 to 10? 7? Is that where you get your back pain? You felt it go down your leg? All right. So we have 6 out of 10, 8 out of 10, 7 out of 10 concordant at all 3 levels. I got news. When you wake up, you'll be done with your surgery. I want you to count out loud for me from 1 to 100 in Portuguese. Okay. Start counting. Blood pressure. Can we keep an eye on that? Shot. 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 Can you see it? The guide wire? Shot. Shot. Luis, you see it in the disc, right? Right there. Yeah, that's what I'm seeing. Shot. Perfect. So we place the guide wire, the needle, now the dilator goes down for our first out of hopefully 6 discs. Keep counting, you're doing great. Num num. All right, any questions from the audience?
No current questions.
Great. So I'm just going to keep working. Why don't you show our audience one more time, Sean, the video of, lay still, the video of how do discs actually cause back pain. Sean? Actually, and after that, we're going to show them what a microdiscectomy is and why it's so bad.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com. A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Okay, welcome back. And did they watch both videos?
Yes, sir.
So they saw what a microdiscectomy is and how bad it is, right?
Correct.
Why we don't do them at Duke Spine. Because they don't work, most importantly. Second of all, because, where's my pedal? My pedal? My pedal? That's you, Omar. Wake up. I got it. I don't want to step on your little hand.
I do have little hands.
All right. Anyway, point is that, take that. There's a piece of herniation blocking our view. Point is, the microdiscectomy is an old technique. It's been around for 80 years, and it's very destructive. It's the way surgeons used to treat disc herniations that caused leg pain or radiculopathy, pinched nerve causing weakness, numbness in the leg. And, you know, for many years it was the best we had, and it was fine. You know, it really helped some people, but it ended up giving them instability and then back pain, and then ultimately they need a fusion afterwards. But then along came transforaminal endoscopic surgery, developed by a professor at Pittsburgh, Dr. Parvis Camben. And Dr. Camben developed this approach of going through the hole that's already there, not damaging the spine, not causing more damage to the spine than is already there from the herniated disc. So Dr. Camben said, okay, let's go through this foramen, right? And everyone thought he was crazy at the time, because to go through the foramen, here you go, you have to go underneath the nerve root, and you know, people didn't know how to do that. So they were really worried about the procedure because it was a new idea at the time, and this was back in the 90s. long story short, over the last, well, since the 90s, 30 some odd years, the technology has been improved upon by different doctors, different manufacturers. Lay down. So I'm right near his painful part of his disc.
You're doing great, my friend.
Yeah, you're doing great. And they took this transforaminal approach that Dr. Camden developed and started making instruments for it. And at first the instruments were really big and bulky, and they were dangerous, to be quite honest. We wouldn't use them today, but the early on instruments, they were the first attempt to do the surgery. And of course, they really didn't have endoscopes like we do today that are designed specifically for the spine and the discs. So Dr. Camden had to work with the endoscopes that were actually available at the time, which were really knee endoscopes. And Dr. Camden did the best he could and designed tubes to go in here that were big and bulky. And of course there were all kinds of problems related to that. But it didn't give up, and he taught some of his orthopedic surgery residents, fellows, how to do this surgery. And one in particular became my mentor. His name is Dr. Young, Anthony Young, Y-U-N-G. Dr. Young has recently retired, doesn't practice anymore, but when he retired, he told me he had done around 10,000 endoscopic transforaminal lumbar surgeries, 10,000 patients, over a career of some 25 or 30 years of doing them. And Dr. Young and I got to know each other very well, and he and I had a lot of mutual respect for each other. We still do. And he's actually in Phoenix and trying to obviously promote endoscopic surgery over more traditional types of surgery like fusions, right? I have an idea, Luis. Don't let me make a mistake. Since we're in 5-1, the disc is open. Let's try to advance the other side. The needle. You know what I mean? Joe Green? Anybody know who Mean Joe Green is?
Yeah. He
All right.
puts it in for the Steelers.
Yeah.
It's a Coca-Cola commercial. I'm a Steelers fan.
Back in the 80s, Mean Joe Green. And everyone would walk around saying, you know what I mean, Joe Green?
I'm PS4L.
What's PS4?
Pittsburgh Steelers fan for life.
Not me. You know what fan I was?
Probably like the Rams, Los Angeles Rams.
All right.
You like the Raiders. One of the
Good. I was a Rams fan, smart man. But I was also a Dallas Cowboy fan. Do you know why? Why?
America's team.
No. I'll tell you why. Because the Dallas Cowboys were practicing spring training, summer training. They practiced in my town, Thousand Oaks, California, back in the 80s at California Lutheran University, CLU.
Why do they need to go there? They have nice weather in Dallas. That's not too bad. They still do, right?
I don't know. Maybe it was summer. Maybe it was just too hot.
Yeah, probably cooler over there.
All right, don't move.
Oh, no, you're doing great. Keep your head down.
Lay still. But this is, the reason he's moving is this is that painful disc we're fixing.
Give me some
You're okay. Everything's good. You're doing great. Yeah, I know. Don't move. Lay still. All right, good. We're done here. Take.
lights on, please.
Let's get the dilator, because what I want to do is put the dilator back, and then let me have the betadine. Just gonna put a little bit in there for a minute. Here you go. Then I'm gonna advance the dilator, because what I want to do here is I want to keep the 5-1 open while we
Well, we don't. On this way.
mallet. Huh?
This will be straight. This will be straight. the tubular retractor, and then we go with a different dilator over here. We remove this side.
Yeah, but we're gonna do that, but we're also gonna place the needle, right? We're gonna finish the needle. So I need to advance the tube. Let me have the outer.
Let's do the canal. No stuff. No?
Huh?
You don't want to do the canal.
What do you mean?
The canal and all that stuff. No want to do.
I do. I'll do it.
Okay.
But I got to get the needle in first, right? We got to put a guide wire. All right, let's get the. No, I need to put the needle first. No, we're not in the disc yet.
Okay, we're gonna come.
I need the stylet. We should be awfully close at this point, right? It almost should just go in, but let me just see. All right, so anyway, the Dallas Cowboys were training where I live. So we used to go out every day that we could and hang out, watch them, and get their autographs, you know? All right. Uh-huh.
They were our arch enemies, arch rivals. Back in the 70s.
All right, so any way I can see that other needle a little bit better? I know it's tough. You know what I can do is take this out. Let's get that out and leave the tube, and that will give us the best view. We're trying to deal with a situation, Sean, where the needle that we've tried placing is bumping up against the superior end plate. Let's go with an AP view. And now that we've opened the disc space up a little more, we can actually probably get into it a little better. I'm going to try. This is the one where the side where the nerve is really pinched badly. And he was really uncomfortable. I mean, I can feel arthritis everywhere. This is probably where his discectomy was. There's a massive amount of scar tissue. Stay there, just let me think for a moment. It's crazy. This is where the discectomy was. I could feel all the stuff around the nerve root. It's bad. That's where all the scar tissue is. Luis, what do you think? Guide wire?
That's what I'm thinking. Guide wire and then
And just do our best? All right, let's go. Guide wire dilator. That's what we're going to do. Huh? Hold that. Yeah, you're there. You're as far in as you can go. Now, no way to do this with the patient asleep. I mean awake, that's for sure. Shot. All right, I see the guide wire there. It's nice. Here we go. So again, we're modifying the technique a little bit, and you have to be able to do that in surgery. How's blood pressure? Good. Looks beautiful. Shot. This patient had, unfortunately, a surgery at L3-S1. We saw the scar on his back from before. He had it done at Biospine, and he was no better when he was done. You're not gonna like this. That looks good. That looks damn good. He's not liking it, but
I gotta, hold on a second. Give him some more medicine.
give me an AP. We're just gonna check the AP real quick. Shot. Lateral, perfect. Look at all that garbage over there. Show them all the arthritis from, see the bone there? I think they actually try to do a fusion. All that stuff, yeah, all that is looks like almost like bone graft, like they stuck bone in there.
Hold on one second.
Lay still, lateral.
Hold on, I ran out of fluids. I gotta give him some.
Nurses, we need help. He needs fluids. You're doing great. Lay still.
Come on over here, Al.
So what we did, for those of you watching, it's a little trick. We got in on the right side at L3-S1. We opened up the disc space by getting the tube in. Now the tube is literally holding the door open. And now we're going to try to get in on the left side while we got the right side open. While we pulled the bones apart, we got it open, and he's more relaxed now because he's in less discomfort from all the pain. And we got him, under anesthesia. Let me know when I can proceed. So now I'm going to be able to get this dilator in and get the surgery done on this side. Tell me when.
Yes.
Proceed. Man, it is bad. That's what I can tell you. It is bad. Wow. All right, perfect. You're doing great. Feel bad for him, We're going to clean this side out like we always do. The fluid adapter. There's no suction on it. Don't move.
We're adjusting his mask. He's fine.
Sucky, sucky. All right. Any questions? So for those of you who watch these surgeries a lot, you'll see we're changing things up just a little bit. That's enough. Because we're going to clean the other side anyway. We're changing things up out of necessity. The reason is that I couldn't get into the right side earlier because he was in too much pain. And it's so narrow and tight in there where the nerve is getting pinched. And the other surgery he had done really screwed it up even more. He had that microdiscectomy. And unfortunately, those surgeries don't really help people very much. And if they do help you, it's temporary. All right, the good news is we are in on the other side with the dilator, so we can bring the tube down. And what are you doing? Oh, no, we're going to do that.
You want to do this one first?
All right, do you want to just leave it? So you got another
Yeah.
dilator?
Yeah.
Oh,
Yeah.
okay, fine. Fine.
And then when we come back
Yeah.
over here.
I mean, the problem is, though, that the nerve is getting pinched over there from all the stenosis. So I'd rather get that side done.
Yeah, no problem.
Let's do that side. Why don't you swing around here, put a little pressure, while I come over there and do that side. So we're going to change up the plan, the game plan, because the L3-S1 is so bad. And I'm just worried about the foramen over there being very tight. Watch out. So I want to decompress the left foramen at 5-1 before I go any further. Get the pressure off the nerve root. Any questions?
Yes, we have a question from Ed K on YouTube.
All right, Ed.
They asked, is it possible to remove central herniation at L3-S1 level, closest to the spinal cord?
Yeah, is it possible to remove an L3-S1 herniation that is central? It is not really possible to remove it all from this procedure because we're going transforaminal. Is that the tube I'm seeing? Yeah, right?
Yeah.
It's in.
Yeah.
Let's pull yeah, we're in. The answer is the surgery can work at L3-S1 even with a central herniation, but you're never going to get all the herniation out, no matter what technique you use. Our goal is not to make the disc look normal by getting all the herniation out. Our goal is to get rid of signs and symptoms. Signs are weakness, numbness, And symptoms are pain and weakness, numbness, per the patient's report. So if we can get rid of pain, weakness, numbness, tingling, then we've succeeded. But the disc will never look normal on the MRI. I don't know if that answers your question, but there's no surgery in the world that can completely remove it.
Thank you.
All right.
We have a few more questions.
Yeah, I'll take your questions.
This next one comes from Miran on Facebook. And they ask, "Good evening, doctor. Thanks for broadcasting your work. What causes arthritis in the discs? Is there anything one can do to prevent it? And does the surgery alleviate pain from arthritis?"
Yeah. Welcome to our broadcast. So what causes arthritis? Arthritis is inflammation. What causes it, if you look at the videos we show you, it's due to an injury to the annular tear, to the annulus, called an annular tear, and then the nuclear material gets into the tear and causes inflammation. So arthritis is inflammation. It's due to trauma inside the disc. All right? This is where he had his surgery. I'm sure of it. Look at this. Piece of bone just sitting there from his prior surgery that was crushing the nerve. We didn't do his prior surgery. It was done at Biospine. And they put bone graft here, is what it looks like to me, in an attempt to fuse this patient.
Feels
Huh?
feels
I can't hear you.
feels like.
Yeah, it's
Like
bone
ice
graft
hard,
for
yeah.
sure.
Yeah.
This is not normal at all. And when I saw his MRI, he was complaining of right leg pain. Well, I saw his left side, and I said, this is really bad on your left. This needs to be treated. Yeah, look at that. That's crazy, huh? Poor man. Anyway, so to answer the question that was asked of me, the arthritis comes from trauma or injury to your disc that then causes inflammation as it tries to heal. The problem is it just never heals. Look at that scar tissue from his prior surgery right there. That white wall at the top. That is not normal. Oh man, that is not normal at all. All right. Well, I'm going to do my best to clean all this up. I got several pieces of bone that were left by the other doctor. And you just saw them. I took them out. I'll see if I can get any more. I think they tried fusing this and it just didn't work. It backfired on them. All right, let's get the laser in for this. Grab that. Yep. Whew.
We have another question.
I'll take the questions.
This comes from Sean Wilson on YouTube.
All right, Sean.
And they ask, "Can you explain what creates a protruding disc in the neck?"
Yes. Can you run the video for him showing how a herniation occurs? That's the what causes neck pain, or if you have that available.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. So what I'm finding here is just really a lot of stenosis that was just left here by the prior surgery. And the disc is extremely collapsed, so it's not an easy situation to deal with. As a matter of fact, things were so tight, we couldn't even get into this area earlier. We had to wait until the patient was more asleep, and then we had to bring in the tube on the other side to give us some space to help open things up. Well, there's fat. The actual nerve root is right there, just north, just to the left. So it's not, let's see if I can clean out a little more of that disc.
We have another question.
Sure.
This comes from Sean Wilson once more on YouTube.
Yeah, Sean.
He asked, was wondering if there was a difference between a herniation and a protruding disc.
Yeah. So Sean, there is no difference. A protrusion is a herniation. There's just many names for the same thing. I don't make all these names up. If I were to choose, I would just say herniated disc, because it keeps it very simple. There are just smaller herniations, there are larger herniations. But the truth is they're all herniations. All right, that's as much as I can do here.
Lights on, please. Thank you. Yep. Scope off.
I'm going to put a little antiseptic. Irrigate it out. Yeah, there are 10 different names for a herniated disc. Protruding disc, ruptured disc, lip disc, bulging disc, extruded disc, migrated disc. I mean, the list goes on and on. They're all the same. It's so funny because you have all these names for basically the same condition, and the disc is a very simple structure. It literally has two parts, a jelly center called the nucleus, and then a wall around it called the annulus. And there's nothing magical about it. It's just a very simple structure, and everything happens because of the tear in the annulus. It all starts with an annular tear. And then once your annulus is torn, I'll just stay here. Okay. Once the annulus is torn, then what happens is, here, the nuclear material pushes through the annular tear and escapes. And half of it gets stuck inside the annulus, and the rest of it protrudes outside behind the disc. And that stuff that sticks out behind the disc actually is the dangerous stuff that can pinch nerves and pinch spinal cords and cause damage. So again, the herniation is quite simple. Is that it? Yes, right. So it's quite literally a tear and the movement of nuclear material shot. Let's go out of the tear behind the disc where the nerves are. If the nerves are compressed, then you get weakness, numbness, tingling. If the nerves are not compressed, then you can get back pain or even leg pain. which comes from irritation of the nerves from inflammation within the annular tear. All right, shot. We're going to enter the number 3, 4, I apologize, 4, 5 disc on the left. After I'm done here, I'm going to go to the...
Good?
Yeah, let's go. I'm going to go to the 3, 4 disc above this. Then we're going to switch sides and go back to the patient's right side and finish up the 3, 4, and 4, 5. Done. Get it out. Fluoro out. Great questions.
Blue towel, please. Thank you. Scrub on. Sealing. Yeah. Thank you.
I need the scope. Let's go. Come on. Oh, it works. But it requires you guys to switch it. All right, if you have questions, I'll take them. If not, sit back and enjoy.
No current questions.
We've already pulled out several pieces of herniation on this side. I'm just going to keep working then. What's your laser setting?
It's 3 and 15.
Okay. So you can see the laser up top at 12 o'clock. It's got a glass fiber. That's actually not the laser itself. That is just how laser energy is transported. Kind of like you would go to the bathroom and get a cup of water at night, bring the cup of water to your bathroom. The cup itself is not the water, but it's used to transport the water. With lasers, light is transported, the laser energy is transported through glass tubes from one place to another. The actual laser machine is much bigger, and it's at the patient's feet. It's the size of a large suitcase, really big suitcase. So right now I'm vaporizing the pieces of the herniation that are stuck within the annular tear, causing the annulus to cause back pain. There's part of the tear right there. You guys see that? Look at the pink material. That's inflammation. That's the arthritis of the disc. Get rid of that and you get rid of the pain. What do you think?
I'm not impressed.
Me either. Waste of time? Yeah? made up your mind?
I mean, at least,
It's either yes or no.
yeah, but just help me on Fridays.
Hmm?
At least help me on Fridays.
What do you mean?
With the money.
Yeah?
Yeah.
So your answer is no, right?
Not right now, yeah.
Is that going to change? Thank you. Wow, look how bad that is, guys. That's not bleeding. That's blood vessels. That's inflammation. Actually, you know what? Henry, that's a good one.
I can
Let's-
screenshot it. That's no problem.
Let's wait till the blood air bubbles go away. Let's get a picture of that. Do a screenshot. Maybe I can stop the irrigation for a second. Get a picture of that. Bang it out. Is it blurry?
No, not really. It's pretty clear to me.
All right, get another one. Get a bunch of them.
Copy that.
All right. And you'll save that in a special folder, right?
Of course.
And I guess this video has to go in there too.
I have a special.
It'll be a double copy. All I want for Christmas is my granulation tissue removed.
You see, right? They're hard.
You mean today?
Yeah, right now. Yeah.
Oh yeah, no, it's no doubt. Yeah, I know. Yeah, it's bone graft. They put bone graft. I think they tried to do a fusion. They probably billed for a fusion, I'm sure. Huh? Right. Well, I'm not going to talk too much about it because it's just makes me so angry. They do it so they can bill for it. They don't do it to help the patient. I wish I could. My legs are getting tired though. I don't know why. Still disappointed about that cervical. Grab her. Ay, ay, ay.
Sorry, what do you say? Thickness? Fixed dilator. Good, thank you.
You mean the guide wire?
No, we don't. So I fixed the dilator, had a bunch of bone inside.
Oh,
So I cleaned it out.
good.
Oh, the dilator? Yeah.
Nice.
Thank you. So I cleaned it.
You're a good man. Almost done here. This is the apex. So all this material coming out, the blue stuff that I'm removing, the herniation, is just pinching the nerves. And that's why people get leg symptoms. This is the back of the disc at this point. This is the L4-5 disc, left side. Remember, discs have two sides, left and right. It's the herniations in the back left or back right that really cause all the symptoms patients get from a herniated disc, or a degenerated disc for that matter. See the sparking that's happening? It's not really sparking, it's all underwater, but you can make it akin to sparking. That's from hitting bone. So that's bone spurs I'm removing when you see that sparking. That yellow stuff's just fat. We're not here to take fat out, but it gets in the way sometimes, and sometimes I actually have to zap it. Looking good. The nerve root's going to be in that fat right there, but can't really see it because it's buried in fat, which is good. That's what it normally is. All right, we're done here.
Lights on, please. Lights on. 1 second, please. 1 second, please. Okay.
Scope off. Irrigation. Where's the big irrigation?
He needs that. With this, you know? See how
That's what, 3 down, 3 to go? Any questions?
No current questions.
the roll. The roll. Thank you. Thank you.
All right. Let's get the fluoro in.
Oh, we just got a question.
Of course, happy to take the questions.
This comes from
I
Mir.
can't let my back hit your arm. It's not sterile. Go ahead.
This comes from Mirren on Facebook. And they asked, before laser was used for spine surgery, was it used in medicine? And did you come up with the idea of using laser instead of using other instruments?
Yeah, great question. So Mirren, number one, laser has been used in medicine a lot longer than I have used it in spine surgery. I think there have been a few other surgeons using laser in spine, but not for spine surgery. It used to be used for a procedure called intradiscal thermoplasty, where you could take a laser and run it down a needle, just like this needle here. And let me do it. So the doctor would put a needle in the disc, and then they'd put the laser fiber down the needle, and then they would just step on the pedal. Watch my scope, watch my scope. They would step on the pedal a few times and blast the middle of the disc with the laser. That's not what we're doing, but that is an application of using laser in the spine. So that predates what I did. Lasers have been used in medicine to treat prostate cancer, kidney stones. The companies that own medical lasers are very busy running the lasers around to different hospitals, and they're being used for treating all kinds of things now. The reason why the companies run the lasers around is the hospitals don't want to buy the laser. They're very expensive. Shot? So we decided to buy our own laser because, Shot?
No, kidding.
No. Just pay attention. Because we got tired of relying, Shot? Come on, Jordan, keep me with shots. And when I look up, it means shot time. Okay? You gotta watch my eyes. I mean, if you guys don't mind being here till 10 o'clock at night, we can. Pull it back a little bit. But the faster we are, by cutting out things that are unnecessary.
More?
Shot? Like wasted time, the better for everybody. Shot? All right, that looks pretty good. Shot? There we go. Out. But it takes focus and attention. So I don't think I was the first to use lasers in the spine. I was the first to use lasers to do an annular debridement. And that's what this procedure is, an annular debridement, removing the herniation from the annular tear. Good job. Now, is a laser better than other tools? Absolutely. There is no tool that can do what the laser can do. It's unique in its ability to remove tissue efficiently, safely, and with precision. That's what we're doing. Laser precision. They don't say laser precision for no reason. When you talk about lasers being precise, they are extremely precise as long as they're designed for precision. Everything okay? Patient is sleeping nicely. What you're seeing there, the blue stuff, is herniation. Now, it looks different than the L3-S1 because it is. The L3-S1 was more degenerated. You didn't have the blue fluffy stuff. You had more older, more acted upon disc material, acted upon by the inflammatory system, destroying it. Clearly, the L3-S1 has been damaged for a very long time. L4-5 as well. The L3-4 is the least damaged of the three discs. So in my mind, from what I'm seeing here inside the disc, the L3-S1 is the oldest injury and the most inflamed, most destroyed disc. It doesn't have to be the oldest to be the most destroyed. Destruction is about how much inflammatory damage is done. And so you can have two discs, one that has an older injury but less inflammation. It'll look better than a disc that's newer but more inflammation. But the scar tissue you see in those discs that are really degenerated, it takes years and years to form. The blue stuff is degenerated nuclear material. This is the herniation, basically. Only the herniation stains blue. Nothing else stains blue. So all the blue you see is degenerated nucleus pulposus, which is part of the herniation, the most important part of the herniation.
We have a question.
Sure.
This comes from Patricia on Facebook. And they asked, any help for scoliosis?
Any hope for scoliosis? Yes, Patricia. You don't need scoliosis surgery to have your spine corrected with screws and rods. If you have pain, we can fix that with the laser surgery you're watching now. Most people with scoliosis don't go to the doctor and say, I have scoliosis. They go to the doctor and say, I have pain. If you have scoliosis and zero pain, then you probably should leave your scoliosis alone. So the people that get treated with scoliosis are typically young people with idiopathic childhood scoliosis, where we know it's going to progress and it's going to get much worse. And then, of course, adults with degenerative scoliosis or post-operative scoliosis from surgery causing it, where they're having horrible pain or neurological compromise. Those people need surgery, but they really don't need fusions. And I used to treat them with fusion because that's all I had available. Like everybody else today, that's all they have available. But when you learn that the laser itself can repair the pain in a scoliosis spine, then you don't need to do fusions anymore. So your scoliosis can probably be treated properly with this surgery. It won't correct your curvature, but it will get rid of the pain. I haven't had to do a scoliosis curve correction surgery in a long time. Used to do them all the time because, like I said, that's what I thought was the only treatment available for fixing it. And again, what are you fixing? You have to really ask yourself, what are my goals here with surgery? And I know what the patients want. They want to be out of pain. Some of them want to get rid of the disfigurement, you know, the bad curve, the way they look when they're sitting or standing. They hate it. But most of them are compensated, and they've basically learned to adapt to the curvature and not worry about their appearance as much. But when it starts to get painful, that's when they start considering surgery and treatment. Bracing really doesn't work for adults, but external bracing. But fusion and correction of the scoliosis does work. If I were to do an osteotomy, correct the deformity, and then put in screws and rods, that would take away your scoliosis and your scoliosis pain. But it's major surgery, and for the most part it's unnecessary because we can fix the pain without doing this big surgery by just doing laser. How's he doing?
He's getting to the point where he's not had enough. It's getting harder to sedate. More
Huh?
harder to sedate, more apnea. Long case for him.
Yeah. How long has he been under anesthesia?
2 full hours. 2 hours and 10 minutes.
Yeah, I don't think that's accurate, is it?
That's exactly.
He was awake when I was putting the needles in. Huh?
2 hours and 10 minutes.
He's been what?
He's had anesthesia administered to him 2 hours and 10 minutes.
But he was awake during that time when we were putting the needles in. I wouldn't consider that anesthesia. I mean, I know it's on your billing hours as anesthesia, but he's not really under propofol sedation, right? Isn't that right, Berndes?
Received anesthesia, supposed to take in a room, 2 milligrams of fentanyl, electrolytes, got a couple of sedated our bodies to help function. While we're waiting, he said 2 hours and 10 minutes anesthesia. That's the best I can tell you.
You remind me of this anesthesiologist that trained with us for a while. I don't know why I'm remembering him. But he was doing a fellowship in pain management. And we asked him to do the anesthesia for our cases. And he didn't want to. He just had his own bias reasons. And he said, oh, it's too risky. You know, I don't want to take the malpractice risk. I thought, malpractice risk? What does you have to do with malpractice? Doing anesthesia for spine surgery? Big deal. After all, you're an anesthesiologist. So,
Well, most closed claims are the airway's not secured when a tube is not placed.
yeah,
So I understand his concern.
but it's his job to do anesthesia.
But he's probably thinking that he just doesn't like the tone position, sedation.
Whatever, you know, it's his job to do the anesthesia. No, I'm telling you though. So he didn't want to do the work. He just wanted to go goof off. But I told him, you're not getting a fellowship training unless you do your part of the job, the anesthesia. And he gave me this story, song and dance about how, you know, doing these cases is high risk for him as an anesthesiologist. And I thought, you're just doing anesthesia. So anyway, long story short, he graduated, and then guess what he's doing now? Spine surgery. Oh, hell yeah. So, well, there's a lot of corrupt places out there. Like, you know, I won't mention names, but my point is as long as it was convenient for him, he's happy to take risk. As long as, no, not yet. Almost done, almost done. You know, and then as soon as it became not beneficial to him or convenient for him, then he didn't want to do it. Forget about the patient. Forget about duty. It's just whatever, manipulation of data.
All right, my friend. Put your head down. Your head down. Good.
How's blood pressure?
It was 120 last time.
Oh, 120 is good. He is a little more awake though. All right, we're done here. Let's go to your side. Let's just do the injection. All right. Yeah, there's plenty of irrigation.
Roll. Put your head down, my friend. You're doing great.
Watch the scope.
I'm doing
All right, let's switch sides. You come over here. All right, 2 more to go. Come on in. So we're able to do all 6 discs. We're going to be able to do all 6 with 2 incisions. Good, thank you. Watch your laser here. Shot, is that it?
Yes, sir.
All right, come on out. Just say shot. Shot. All right, looking good. This is going to be L4 on the right. Pull the guide wire back a little. Shot. Nice job. Should be good. All right, fantastic. Oh, beautiful. It's not that tight. You should be able to get it out. Let's go. Fluoro out. Beautiful.
Jordan, lights on, please. Thank you. Thank you.
All right, that's when you want to move the pedal. Okay? You understand, Omar? That's your job. Move the pedal where it's supposed to be. Appreciate it. How are we doing over there? Huh? Able to do the last one? Huh?
I'm hoping.
I'm asking.
Yeah.
Because we're almost done here. And I got one more if you want me to do it. I can do it. Only if it's safe. Huh?
Yeah, I think you should be able to. You should be able to do it.
It's not that bad of one, so I think it needs to be done, but it should go quick. I need just a few minutes left on this one. Last patient's here? Huh? I don't need to hear that. What I need to hear is they're here and ready to go. Because they may have been here for 2.5 hours, but I've been here for how many hours now? Huh? More than them. So we don't need to talk about who's been here longer. Besides, better that they're here waiting for 2.5 hours than at home. Huh? Right? At home they might want to sneak something in. Sneak in a bite. A little bite of a machaca burrito or something, right? That's what I would do. I would sneak in a bite of a machaca burrito. And then Dr. Berndes would yell at me. Right, Berndes?
Yeah. Then I would sound like that other anesthesiologist.
Oh, Rappaport? Not Rappaport. Sorry. Cuppinger, right. Rappaport was actually pretty good. Yeah, he was our first anesthesiologist doing these procedures 16 years ago. He was an interesting guy. I've met some really interesting anesthesiologists over the years. Anyway. All right, we're done here. That looks good. Let me just verify, hold on. The nerve is going to be right over there in that fat. Looks good to me. Scope off. Let's bring in the fluoro. I almost said let's bring in the machaca burrito. Where do you get the best Mexican food?
I got a place in Vegas that's the best.
Yeah, where?
Called Roberto's Taco Shop.
Roberto's. That's where I used to go in college. Roberto's. They have the best damn food, right? The carne asada there is amazing. And the machaca. That's where I fell in love with the machaca, was at Roberto's. And then everybody copied them. Alberto's, Robiertos,
That's her.
Rubitos. I'm not kidding.
Some of those names sound familiar when I went to UCLA.
Yeah, yeah.
Robitos was the one.
Oh, there's so many. Rubio's fish tacos out of, I think it was Ensenada. That was really good. Rubio's fish
That's a
tacos.
big chain now, right?
Rubio's? Yeah. Shot? Shot? Yeah, if you like fish tacos, you know, the mahi or
I love fish tacos.
white, battered, flaky meat. Take the guide wire out. Shot? Shot. That's good. All right. Questions from the audience, and don't ask about burritos.
No current questions.
We're getting hungry over here. Did you guys order your Wendy's? You know, I got Moe's for you guys, right?
Yeah.
Nobody likes Moe's? What? Laser? Blue towel? Huh? Honestly, I didn't really like my Moe's today. I had a bean burrito. Bean and cheese. Because they don't do machaca at Moe's. A little disappointing. Machaca. Machaca is one of my favorite. Machaca. You know what machaca is? Huh? Are you kidding me? You don't eat Mexican food? Do you know? You know, anybody know what machaca is besides me?
It's like a brisket of beef. It's like beef.
Yes.
You put it with eggs. You put
Oh,
it with,
stop. It's too much.
and it's flavored
I'm
with peppers and onions and garlic.
Yes.
My wife makes it. It's so good.
Really? Right? If you want me to finish surgery,
There's no good
I'm just
Mexican
kidding.
food here. That's one thing that's in my wife's kitchen. That's it. Alright, we'll go to your house then. She crushes it. She makes the best enchiladas, green enchiladas.
all right, there's actually a decent Mexican restaurant, okay? It's, I want to say Cafe Jalisco? What? It's over on US 1 or over by Cocoa Beach area, by Satellite Beach. It's something Jalisco. Huh? It's one of those, Jalisco something. Anyway, they got pretty good food. As a matter of fact, you want to know something funny? My mom doesn't like Mexican food at all. She never goes. Every time I want to take her to dinner, where are you going to go? Mexican food? No, I don't want to go. So I took her finally to this restaurant. I said, stop complaining. Try this. Now, I call her up and say, where do you want to go to dinner? You want to go to Chinese? No, let's go to Jalisco. I'm like, are you kidding me? You like Mexican food now? She's like, yeah. They have this dish over there she likes. So basically, I think she just didn't have the right food. Now that she has had it, she loves going there all the time. Did you find it? It's something Jalisco. Over on A1A. On the beach side. Over in Satellite Beach. I think it's Satellite Beach. What is it? Yeah, huge lettering. Right? Yeah. What's it called? The one on the little shop? Yeah, yeah. It's like right where the 520, the 520 meets the A1A. Yeah, I know which one you're talking about. Oh my God, I can't think of the name. But I've been there. The food is pretty good there. A little salty, but it's still good.
How much time we have left?
Less than 5 minutes. Well, I can't help my love for Mexican food since I grew up in California. You know? What is a good Puerto Rican dish? What is it? Is that good? I've seen that. Like signs that say it. Mofongo, right? And I'm like, what the hell is that? Is that some kind of vape store?
Plantain, and then they do fill with, I don't know, shrimp, meat,
Really?
whatever. But
It's
very
good?
good. It's actually very good. Which one? Oh, no, that's a... It's gonna happen on your video.
Which one? I've been to Brazilian. I like Brazilian steakhouse. My favorite is Fogo de Chao in Orlando. Have you been there? Food is so good there. I know. I'm the same way. You start eating and you're like, my God, I want more, but you can't eat anymore. Yeah, 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 yeah. Right, they keep coming. All right, 2 minutes. Yeah, they have that bread too, the cheese bread. Oh my Lord. It's really bothering me. I can't remember the name of the burrito shop. I haven't been there in a while. Huh? It's in Cocoa Beach. It's just this little dive. Those are always the best though. I've gotten into the molcajete lately, you know? Oh, I love the molcajete. All that cheese and meat. Mm. I know, it's like a two-person thing. But it's good. It's really good. With the what? I've never had it with cactus. All right, we got about 2 minutes, 1 minute left maybe. Just about done. You can see this is the back of the disc. And the blue stuff, the nucleus, I've gotten rid of almost all of it. I tell everybody you need to get rid of 50% of the herniation really and the annular tear to really get a good result. You don't need 100. There's lots of herniations out there that don't cause any symptoms at all. Patients are symptom free. We don't just treat herniations because there's a herniation. We treat them because they cause symptoms. So it's important to keep that in mind. All right, 1 minute. These are the last bits of the annulus that have some herniation still in them. "30 seconds. Yep, we're done. I'm just cleaning up the last few bits here. Pretty happy. Got a good clean out. This 3-4 was worse than it looked like on the MRI. You know? Didn't look too bad on the MRI, but it's all this is torn annulus and herniation. All right, we're pretty much done.
Lights on the thing, let's do the thing. Yeah, the roof light, yeah. Scope off. Thank you. Yeah, thank you.
Done. Let's take a look at what we've done, folks.
Sure.
So, first of all, can you see this? This is the scope,
Yes, we can.
and you can see how long it is. It's got a camera attached, light source, irrigation, and then it has some channels that I work through right here. You guys see that, Henry?
Yes, we do.
Cool. And then let's show the incision on your side. So we were able to do it all through 2 incisions, one on the left, one on the right. You see that?
Yes, we do.
All right, great job, everyone. Tough case, but we got through it. And we have one more. This next patient is 2 levels of herniation and a DPR, Duke plasma rhizotomy, left 5-1 facet.